bradykinesia plus rigidity is Parkinsonism, and patients with Parkinsonism will be classified into drug-induced Parkinson plus syndrome and Parkinson's disease. Drug-induced, anything that blocks dopamine. Then Parkinson's plus, they have an additional feature. That is why they are called as Parkinson's. So one of them is dementia with Lewy bodies or Lewy body dementia. What is the plus thing there? The plus thing there is dementia. So it is, the plus thing here is dementia. Apart from bradykinesia and rigidity, they have dementia. The second one that I was talking about was progressive supranuclear palsy. The plus thing here is vertical gaze palsy. Patients have difficulty to look down. Second, because they have difficulty to look down, they have frequent falls. Okay. And important image findings that you may get in these patients is hummingbird sign. It's called hummingbird sign. Okay, go through the radiology workbook for the image of this hummingbird sign. Another important Parkinson's plus syndrome that I want you to remember is called as multi-system atrophy. Multi-system atrophy. So the plus feature here in these patients, the plus thing is they have autonomic dysfunction. Autonomic dysfunction. And here the imaging finding that you are going to get is called as hot cross bun sign. Hot cross bun sign. Okay, so these are important plus syndromes I want you to remember. Now coming to the main part, that is Parkinson's disease. Parkinson's disease is the idiopathic. Here drugs or plus syndromes are not responsible. It is an idiopathic disorder. So this is a neurodegenerative disorder. So when it is idiopathic, we use the term Parkinson's disease. But if there is a cause like drugs, we will call it as drug induced. If trauma is a cause, we will call it as dementia pugilistica. When it is idiopathic, we will simply use the term Parkinson's disease. And Parkinson's disease is also a neurodegenerative disorder. Parkinson's disease is a neurodegenerative disorder. So what do I mean by that? Neurons die, just like Alzheimer's. It's the second most common neurodegenerative disorder. Alzheimer's disease, neurons were dying because of accumulation of amyloid beta and tau. Here it is due to accumulation of alpha synuclein, and this alpha synuclein accumulation is visible under the microscope as Lewy bodies. We see them under the microscope as Lewy bodies. So when amyloid beta and tau proteins accumulate in the neurons, and when we see them under the microscope, we call them as neurofibrillary tangles and neuritic plaques. Larger ones are called as Hirano bodies. Here we are calling them as Lewy bodies, which is alpha synuclein accumulation. Here also we don't know the exact cause. We know the risk factors. When it comes to risk factors, age more than 70 years is a risk factor. Apart from that, another important risk factor is genetics. And when it comes to genetics, I want you to remember mutation in Parkin1 is the most common mutation responsible for Parkinson's disease. Okay, now in terms of the clinical features, disease has a progression. So the earliest site to get affected by neurodegeneration is anterior olfactory area, and this area is concerned with olfaction or smelling. So when neurons in that area die, we lose our ability to smell. So anosmia or hyposmia is the earliest overall symptom. So earliest overall symptom, if it is asked in an MCQ in a patient with Parkinson's disease, what is our answer? It is anosmia. From there, the neurodegeneration progresses to locus coeruleus, and once the locus coeruleus gets involved, it leads to autonomic dysfunction. And that produces symptoms like, this will produce symptoms like resting tachycardia. Heart rate is under the control of autonomic nervous system, and once that is dysfunctional, we can have high heart rate even at rest. Resting tachycardia, orthostatic hypotension, From there, the neurodegeneration spreads to substantia nigra. And once the substantia nigra is involved, that is where we start seeing the motor symptoms. The substantia nigra involvement leads to motor symptoms. So what are the motor symptoms we are expecting in a patient with Parkinson's disease? The first is tremor. Tremor is the earliest motor symptom. Tremors. Tremor is the earliest motor symptom. And the point to remember about tremor is that these tremors are rest tremors or resting tremors. And how do we describe them? The tremors of Parkinson's disease are described as the classical pill rolling tremors. Pill rolling tremors. Apart from the tremors, we also develop bradykinesia and rigidity. Bradykinesia and rigidity. Rigidity is a form of hypertonia. There are two types of hypertonia: spasticity and rigidity. Spasticity is seen when there is UMN damage, pyramidal tract. Parkinson's disease, there is damage to extrapyramidal tract. So that produces rigidity. And this bradykinesia itself leads to various other symptoms. What are the other symptoms we are expecting which are arising because of bradykinesia? So bradykinesia leads to first decreased arm swing. Slowness of movements makes the arm swing less. It also leads to decreased blinking of the eyes. Then facial expressions become slow, so we call it as hypomimia or mask-like face. Hypomimia or mask-like face. And their handwriting becomes tiny, small, so we call it as micrographia. Micrographia. So these are all symptoms arising out of bradykinesia. Bradykinesia is the main symptom. It leads to secondary symptoms. Okay. And then rigidity. So as we know, rigidity refers to increased tone where from end to end there is same level of resistance, right? So rigidity affects both core and limbs. And limb involvement in the lower limb, there is no tremor. So it's just a plain rigidity that is called as lead pipe type of rigidity. But in the upper limb, tremor is there. So there is a jerkiness to rigidity that is called as cogwheel type of rigidity. So two types of rigidity we are getting in Parkinson's. Upper limb, rigidity plus tremor. So that is cogwheel. Lower limb, only rigidity, no tremor. So that is lead pipe. And the core rigidity means the core, your rectus abdominis, obliques, erector spinae, the center of the body. Those muscles are also affected. Here, anterior muscles are more affected than posterior. Anterior is more affected than posterior. And what is the consequence of this? Anterior affected more than posterior means anterior muscles are more contracted, so they bend forward. So core involvement leads to a stooped posture. And stooped posture has a tendency to make them fall forward, and to avoid falling forward they accelerate their walking. It produces a gait which is called as festinant gait. So all of that in your workbook is summarized in this picture. So in this picture, as you see, the arm swing is reduced, the blinking of the eyes is reduced, blank facial expression because of bradykinesia, slow speech because of bradykinesia. And then tremor, which is called as pill rolling tremor. Rigidity plus tremor in the upper limb produces what we call as cogwheel rigidity. Lower limb rigidity is called as lead pipe because there is generally not much tremor. It affects but late. Now, core also gets rigidity. Anterior muscle become more contracted than posterior, so makes him bend forward. And when he's bent forward, when he tries to walk, the gravity makes him fall forward. So avoid falling forward. They take short but fast steps. That gait is called as short shuffling gait. So these are the manifestations we are getting in a patient with Parkinson's disease. Once someone presents with these features, I have to go for diagnosis. So for diagnosis, we are following a criteria which is called as MDS criteria. So what this criteria says, the criteria says bradykinesia must and should be there. So we are following Movement Disorders Society criteria, and the criteria says for the diagnosis of PD, you need bradykinesia plus either tremor or rigidity, any one of them. So that makes the bradykinesia mandatory or compulsory symptom. Bradykinesia must and should be there. You need not have tremor or need not have rigidity. Only one of them present is enough. Bradykinesia plus tremor or bradykinesia plus rigidity. Once you have diagnosed it as Parkinson's disease, we will look at its management. I forgot to mention, if you do imaging in Parkinson's disease, generally not required for a diagnosis. Diagnosis is clinical, but if you go and do it for some other reason, you find a finding called as loss of swallowtail sign. Loss of swallowtail sign. What is this loss of swallowtail sign? Normally, the substantia nigra appears like this is how a substantia nigra appears on the MRI scan. It is split into two, and this appearance is called as swallowtail sign. Swallowtail sign. That is perfectly normal. But in Parkinson's disease, there is depth of these neurons, so it loses its bifid or split appearance. It becomes like one, because all the substantia nigra neurons are dead. It is no longer split, it appears as one. So that we call it as loss of swallowtail sign. Swallowtail sign, its presence is normal. It looks like the tail of a swallow bird. Now that is lost. We will call it as loss of swallowtail sign. That is classical of Parkinson's disease. So in PD, we get a loss of this swallowtail sign. Once we have diagnosed, when it comes to management, the key thing you have to remember is that we want to increase the dopamine in the substantia nigra. So there are so many drugs that can be used to increase the dopamine. The most effective drug is levodopa. That's why levodopa is considered as the first line treatment. But then levodopa brings in side effects. Increase in dopamine in the periphery leads to hypertension and nausea, vomiting. So to counter that, levodopa should always be combined with a peripheral dopa decarboxylase inhibitor. So that is why whenever we talk about the first line management of symptomatic Parkinson's disease, we use levodopa because that is the most effective treatment. But to counter its side effect, we use carbidopa. What is carbidopa? It's a peripheral dopa decarboxylase inhibitor. Plus, we also consider using rasagiline. Why are we adding rasagiline? See, the reason levodopa finds its place in the first line treatment is it is most effective. The reason carbidopa finds its place in the first line treatment is it is a peripheral dopa decarboxylase inhibitor, which is very crucial because the peripheral decarboxylation of dopa to dopamine leads to various side effects and reduced efficacy of the drugs. Peripheral dopa decarboxylase inhibitor. Rasagiline is technically a monoamine oxidase B inhibitor, but it has an added advantage. It has neuroprotective properties. And they may ask you an MCQ, which anti-Parkinson drug has neuroprotective properties? The answer is going to be rasagiline. This is a potential MCQ point. This is the first line treatment. If they fail, right, second line treatment primarily includes adding either a COMT inhibitor or monoamine oxidase B inhibitor. COMT inhibitors include examples like all these Malayali names, right? If you remember, entacapone and tolcapone. Monoamine oxidase B inhibitors, you know, rasagiline. which we are using small dose for neuroprotection, but now I can escalate to full dose for the symptomatic benefit, and rasagiline and selagiline. Apart from that, we also have dopamine agonists like the bromocriptine, and so those can be considered. But the typical flow of current management primarily focuses on using the levodopa as the best bet for treatment. So if drugs fail, as third line, we can consider deep brain stimulation, right? It's like pacemaker. We try to stimulate the nuclei in the basal ganglia. So they may ask, what are the currently preferred target for stimulation of basal ganglia nuclei? So the target for stimulation by deep brain stimulation includes subthalamic nucleus, that is also called as subthalamic nucleus of Lewis. And another target that can be chosen is globus pallidus internus, globus pallidus internus, or GPI. These are the targets used for the stimulation. So that completes our Parkinson's disease as well. The next topic from neuro that is important for us is headaches. So that's going to be our last topic from neuro, and then we will go to the cardio. So generally, you know that headaches are classified into primary and secondary. So you have primary headaches and secondary headaches, and you know that secondary headache generally come with some red flag sign. They come with red flag signs are usually present in secondary headaches, and important examples for secondary headache includes the most common causes infections. Infections are the most common cause. Apart from that, you have CNS specific infection, that is meningitis. Then you have intracranial space occupying lesions, and the list goes on and on. The primary headaches generally have no red flag signs. No red flag signs. And these primary headaches are divided into tension type, migraine type, and then we have trigeminal autonomic cephalgias. And these trigeminal autonomic cephalgias are of three types. The first one is cluster headache. The second one is paroxysmal hemicrania, and the third one is Sankt or Suna. Tension type is considered as the most common primary headache disorder, though many recent studies show migraine is more common, but traditional books still mention tension type as most common. Tension type usually runs for days. Here headache is usually bilateral. In terms of severity, it is mild to moderate, never severe. And these patients have the headache distributed the frontal, parietal and occipital region. So usually described as band-like sensation or voice-like grip. So whenever you see these descriptions in a question, you know that these are the buzzwords examiner is throwing at you for diagnosis of tension type of headache. And another important thing, it is bilateral. So whenever you diagnose a tension type of headache, when it comes to management, the drug of choice for acute treatment is going to be NSAIDs, but for drug of choice for preventive treatment or chronic therapy is going to be amitriptyline, which is a tricyclic antidepressant. So NSAIDs are considered as the drug of choice, and amitriptyline, which is a tricyclic antidepressant, is considered as a drug of choice for preventive treatment. That's about your tension type of headache, right? So next, let us take migraine. So when we talk about migraine, migraine is primary headache which is bilateral. This is it is unilateral. This is cranium predominant headache, so primarily affects orbits, forehead and occipital regions. In terms of the pain, this is moderate to severe. Moderate to severe. Migraine is never mild. In terms of duration, it lasts for 4 to 72 hours. Headache lasts, the tension type lasts for days. This lasts for 4 to 72 hours. And this may be associated with some additional symptoms. What are those? One of the additional symptom is aura. What is aura? Abnormal motor or sensory perception that occur before the onset of headache. Aura phase. Aura can be typical or atypical. So when it is visual aura, we call it as typical, and anything else will be called as atypical. So atypical includes hemiplegia. Okay, then retinal migraine where vision loss occurs. So these are all brainstem dysfunction where cranial nerve palsies happen. These are all atypical aura. Typical aura is visual. Within visual, you can have seeing floaters, zigzag lines, or like they can see floaters, zigzag lines, or flashing of lights. And you have to also remember that this aura that we're talking about is a reversible symptom. It's not a persistent